The topic for today is the full arch market prospects challenges. I'm very much honored to introduce the speaker for today, Dr. Ali Mostafavi. He was an aeronautical engineer to start with before switching his field to dentistry. He earned his BDS from Annamalai University. I'm proud I'm also from South India. This is in South India. And later on, he completed his DDS from his country, Iran. He began his implant career in 1999. He's a fellow of American Academy of Implant Dentistry. In 2018, he completed prosthodontic program from Eastman Institute, Rochester, New York. Please post your question in the chat window. Warm and very big welcome to you, Dr. Mostafavi. All yours, sir.
Thank you very much, Dr. Prasad, for your introduction. I'm very happy to be here. I consider India my second home, if you would. I lived in India from the age of 17 to when I was 29 years old. So I'm pretty much Indian. Okay, the topic of discussion today, let me share my screen. Other considerations of doing a full arch case in terms of patient management, staff training, financial part of it, and things about that usually you don't get to learn, or you don't get speakers to talk about it. Or if you do, you get these presentations in different parts, in different situations. So at this time of where the world is undergoing major changes and you see COVID-19 affecting all parts of our life, I think this presentation will be very helpful for private practice owners. I do know that nobody knows what to do and where to go. So I think I have gathered hopefully good information for my peers who are owning a practice and who are looking into entering full arch dentistry. So let's see what's the full arch market. Let's answer these questions. Is there a need for full arch to begin with? Let's go over some statistics and see whether there are enough number of cases so that I, as a practice owner, would even want to enter into this market to begin with. How is it different from other areas of dentistry? After all, I, as a dentist, have been trained to save a tooth or at the most replace a tooth. So if I can replace a single tooth, I also can replace a couple of teeth. So is it really different doing a full arch case? So let's see how different it is from the technical aspect of it. Do I want to include full arch into my practice? That's a major question that I try to answer here. And what does it take? What changes do I have to implement in my practice to involve my team and my practice into full arch and provide the services for my patients? After all, is it worth the effort? Honestly, we are all dentists to make a living. Yes, we are here to help our patients, but we are not running a non-for-profit organization. We do like to provide our services and our training to our patients, but at the same time, it should make financially sound for us to run our practice and to earn a living out of it. So I'll briefly go into economics of it. And now that I have decided to include full arch into my practice, where do I look for help? And that's where synergy specialists come into the picture. And we are lucky to have Darius here, CEO of Synergy, to talk about how Synergy can help out private practice owners in achieving their goal. And finally, but not the least, an important question to answer: how is this market affected by COVID-19? I'm pretty sure that what you are going to hear would be very interesting for you. So, to begin with, when we talk about full arch dentistry, automatically the major market comes to, okay, this is a baby boomers market. Yes, it is, but there are other people also who are full arch candidates that we'll see. But who are the baby boomers? Baby boomers are those who were born right after the World War II, and due to the major changes and major improvement in industrialized countries, major improvement in all aspects of economy, healthcare, and so on and so forth, the age expectation of these people had increased so much so that now you are seeing people living up to 90 years old. So the longer you live, the longer you need necessities for life, and teeth are not an exception to it. But how about the other people who need full arch cases, full arch restorations? So patients with congenital disorders like enamel hypoplasia leading to rampant caries, uh, partial anodontia, total anodontia, ectodermal dysplasia, and so on and so forth. So these are the cases that you may come across in your practice during their journey into their life. And ultimately, they are potential candidates for full arch cases. Denture wearers. In my view, denture wearers are a very good candidate for full arch cases. Why? Because they have already had dentures and they have experienced it, and now they want to upgrade the prosthesis that they have. They want to upgrade their lifestyle. So they are potentially very good cases for for full arch prosthesis. And we have a small group of population who are gaggers and who cannot tolerate any kind of removable prosthesis to begin with. So they are also potential candidates for full arch prosthesis. Let's see a couple of cases that I have done during my residency program. So we talked about congenital dental anomalies. So here you have Stephanie. Stephanie is suffering from ectodermal dysplasia, and you know, during residency program, the cases get delayed and they get over and over. So as a resident, you get a case is inherited to you, you do your part, and then the case goes over to the next resident. So Stephanie began her treatment much before I joined the program. And when I joined, she was all set with all these implants after major, operations and bone graft and so on and so forth in the oral maxillofacial surgery department at University of Rochester. And then she was referred to us for the restoration. Now, you may ask why those two molars are kept. Again, you will see during the presentation that doing a full arch is not only replacing teeth, it is a psychological impact that the entire scenario of going edentulous has on the patient. So this lady in her 30s, she insisted on keeping these two molar teeth because she didn't want to be edentulous. She considers herself having some teeth, okay, simply because these two teeth are here. And this is the final restoration, lower and upper hybrid restorations. And this is Stephanie before and after. So dental caries. Dental caries, this patient is a gentleman in his, again, mid-30s. So the remaining three lower teeth have major caries, gross caries. So these teeth were extracted, and the lower arch was, as you can see here, the lower arch was restored with the FP1 type of restorations. A gentleman, Tom, in his late 60s, with multiple carious teeth, multiple crown, and all sort of restorations which are failing one after the other. and the case was restored by a hybrid kind of restoration in the lower arch, maintaining the two molars right at the back throughout the treatment to maintain the occlusal vertical dimension throughout the length of the treatment. In the upper arch, we ended up in restoring him in FP2 type of restoration. And in the lower arch, this is a hybrid case, an all-on-4 type of prosthesis. So what is the typical profile of the patient that you see? This is a panel again of one of the patients. So here what you see, the picture, the panel is talking to you that, hey, this belongs to a patient who has been having a lifetime history of multiple dental treatments, much redos, many dentists. You can see that from the quality of the dental work that has been done, multiple restorations in the anterior teeth. Now here I want to mention what is our responsibility in treating these patients. I'm pretty sure that she has seen many dentists. I'm not sure if any dentist have talked to her about, hey, lady or gentleman, you need some posterior support. Unless you have some posterior support, you cannot maintain your teeth for a longer time. So anyhow, you will come across these cases wherein a couple of teeth are good to begin with, and then the question comes whether the patient at this age should be moved into a full arch case, or rather we should take a decision to treat each teeth by teeth. And that's a major consideration that comes into the picture during treatment planning and consultation. What does the statistics show? The statistics show that by 2020, which is this year, we have in the US 40 million people in need of dentures in one arch or both arches. And 90% of these edentulous patients are going to seek treatment, some form of treatment. And add to these numbers, add to these 40 million numbers, the patients who are already denture wearing and who are looking to upgrade or change into a more stable kind of restoration. Consider you only taking care of 1% of these numbers. You do the maths and you will see whether it is worth entering this full arch market or not for yourself. Again, population studies. Every single day, 2020, every single day, you will see 10,000 Americans entering the age of 65. These are the baby boomers. These are the markets. Interestingly, only 10% of the marketing is directed towards this age group. So, what is the typical psychological profile of the baby boomers? They are either retired or are entering the age of retirement. They have had typically a lifelong history of dental treatment. Many redos have been done for them. They are looking for, and they are tired of all these, individualized considerations of the teeth, and they are looking for a final kind of treatment. They are kind of done with it. They want to get something which is going to last them as long as they live. Generally, but not as a whole, but generally, at the age of 65 or so, 60, 65 or so, they are in a moderate condition of systemic health. I would say ASA2, wherein they are more stable, if any major surgical procedures are going to be done. And as you know, as you get older, there is higher morbidity. So now the question comes, if we as dentists see a patient at the age of 60, 65 with the panics that I showed a couple of slides before, do we think that this candidate at the age of 60 is a good candidate for a major surgery, meaning total extraction of both the arches, bone grafting, and implant placement? Or can we delay this major surgical operation to the age 70, 75, 78? I'm almost sure that you all agree with me that if we foresee that major surgery down the line for this patient, we would prefer to have it earlier than later for the sake of systemic condition. As you get older, you your adaptation is minimized. Any kind of change, no matter what, whether it is going to be a change in your house, whether it is going to be a change in your car, or a change in your mouth, your adaptation is going to be at the lower degree. So sooner, better than later. And again, as you get older, you get less patient. You 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 try to prevent so many visits for restoring your arch. You would rather have it at an early age. So other psychological changes that come with the baby boomers are, once you get retired, you hit a depression which we call a retirement depression. In most cases, luckily, it goes by after a couple of months, but in some cases, it stays back. You get a feeling of being left alone by your children because you have invested in your kids, raising them, and now you see that you have grown, you need help, but the kids are gone. They have their own family. So that has a major impact on psychological condition of the baby boomers. They become less tolerant. Less tolerance. They have high irritability when you talk to them. If they feel anything, quickly they will get out of the nerve, okay, and they demand tender loving care or TLC. They need respect. They need you to have compassion for them, to have sympathy for them, and they are looking to have tender loving care wherever they go, including our private practices. At the same time, we have to take it into consideration that as you grow older, your level of comprehension and cognitive comprehension lowers, meaning that during the treatment planning session, during the consultation, and even after that, we need to be more patient with them, explaining details slowly and making sure that they do in fact understand what they nod on their head to. Because in many cases, they feel ashamed or they feel embarrassed to ask you that, hey, doc, I didn't understand what you were talking about. So they simply nod their head. And after a while, we realize that they did not understand what we were talking about. So the staff members in your practice, starting from the front desk, from the treatment coordinator, the assistant, or your radiology technician, if you have one, they all have to be trained in dealing with baby boomers. So as you grow older, decision making becomes difficult, which means it is recommended that you do have the spouse members during the consultation and treatment planning, and also uh, any person who is responsible or who is involved in decision making for the health of the patient. They have to be included in each discussion about the consultation and treatment planning. Make sure they understand the point during the treatment planning before you jump on to the next point, and give enough time for them to ask their questions and make sure they understand one point before moving on. Having models, physical models in your hand, in your practice, to actually show them and let them feel it, let them see it, see how it looks like, is way different than having something explained verbally or even having something to be shown on the catalogs or the pictures. There's nothing, we call them $1 million models, okay? And we have them in my practice. We give it to the patient and they can see and feel exactly how it feels and how it looks. That makes a major impact on them. And then present the treatment plan estimates, not in the form of our CDT codes, which makes no sense for the patients, but rather in a kind of essay form. What I do in my practice, extraction or pulling your teeth, just pulling 12 teeth costs you so much. Your temporary denture would cost you so much. Your implants would cost you so much. And then the grand total, rather than having all those CDT. Now, if for any reason you would prefer to give them an itemized billing statement or estimate, my recommendation would be on top of that, give them an essay, kind of a single page format. Option one, uh, full fixed prosthesis would cost you A to 3 this much. Option two, overdenture or a snap-on denture would cost you this much, and so on and so forth. That makes it much easier for the patients to understand. Now, unfortunately, we have to blur the eyes of this lady, but think of the major change that you, as a provider, would have brought into this lady's life. I'm sure you all agree this lady will be very much apprehensive of going in public, taking part in social, gatherings and things like that, because the way her teeth look. Look at this lady. Do you think that this lady is now more confident in venturing out into social gatherings, in going out with friends and family members? So these are the type of changes that we can bring about in day-to-day life of our patients by providing them with our services. So the take-home message here would be full arch consultation is way different from the routine dental consultation, wherein you tell the patient, okay, this tooth needs root canal, a post-encore, and a crown. It is way different. You want to have the spouse members inside and all the things that we talked about. And we can have another discussion in simply talking about how a treatment planning consultation should be framed for a potential candidate for full arch case. We need to have an insight into geriatric psychology. We need to get to understand our patients. Many a times, especially when the patients come to you for a second opinion or the third opinion, they have already set up their mind as to what they want as far as the treatment is concerned. They are just judging you whether you are the right candidate that they want to pay you 20, 30, $50,000 to take care of them. So take it into your mind that treatment planning and consultation with full arch cases is not only about us explaining what should be done, it is also about our patients judging us whether they can trust us to be their provider. So that's an important thing to consider. We need to have, or we need to develop and upgrade our senior patient management skills. It's not only about us, it's about our entire team. Entire team has to be trained on how to deal with senior people. They respect dignity, respect. I'm sure that all of us do the same thing with all sort of patients, but when it comes to elderly population, they become, as I said, more irritable. So there are some fine tuning is needed. And we need to be patient with our patient. And we need to understand that we cannot make each and every patient 100% happy. And we have to understand that it's part of the game. When you enter into dealing with geriatric cases, and we need to have, I think we need to have a strong psychological background to kind of deal with these kind of situation. And that's why having a family member during the procedures, during the consultation, and during the journey of the treatment is very important because they understand what we are going through. And we need to consider that here the patients are considered, I consider them as a lifelong client, not a patient. They are going to have the denture or the prosthesis delivered by you down the line. You know, I know, and the patient also should know that no matter what we do, no matter how much they pay for the services and the prosthesis that they get, it does need maintenance on our part and maintenance on patient's part. And they are going to like us. I mean, they should like us because they have to come and visit us so often. And so we also should like our patients. So there should be a mutual trust and understanding before between the patient and the provider. And again, the team has to be trained on all these philosophies. Financial considerations. It is very, very important when it comes to full arch. Statistics show that 97% of the high-end car market, the people who buy high-end cars like Lamborghini, Bentley, Rolls-Royce, they all finance. Does it mean they don't have money to buy that? No, they do have the money, but when you finance, you are actually raising the value for your money. You are actually raising what you can do with what income you have. So we have to make it financially affordable for our patients. The patients are usually shameful for talking finances and they bring about other excuses. So it is, I think, up to us to bring the finances and financial considerations to the patient and show them how easy it could be solved. The key is to make the treatment affordable. Now, by affordable, I do not mean to make it cheap. I mean to make the payment plan affordable or rather tailor-made for each individual patient based on the financial situation so that they can easily pay for the services. That way, you are going to keep the patient in-house rather than the patient moving on to the next door, to the next practice. It is very interesting to know that the more patient financing programs you have in your office, the better would be your chances of getting the cases accepted. Because, as I mentioned, financial consideration is a major point in deciding over the treatment or rejecting it. Nowadays, many practices are thinking about in-house financing, and maybe that's something you want to think of to provide for your patients. Now, finally, let's see whether COVID and the situation that the entire world is now in is going to affect the full arch market. I do not think so, because I think patients are going to lose teeth. The patient are going to need teeth no matter what. And the patients prefer to have fixed restoration rather than removable restoration. So when it comes to baby boomers, think about the baby boomer market is not going to be affected by economy of COVID-19. Why? Because baby boomers, by definition, are either retired or at the age of retirement. So they are not living on employment for making a living. They are living on their investments for a 1K plan, whether they have a, I don't know, investments, stock market. So they have all throughout their life, they have made up an investment plan for their retirement age. So it is up to us to convince them that is the treatment we are providing them, is it worthwhile for them? If they do understand the value of the services that we are providing them, they will pay for it. They have no issue with it. Now, regarding the other segment of the full arch cases, the key to winning these cases would be of course, we have to lower our profit margins. You see that in every part of the economy. You see the restaurants. The restaurants are having now a lower margin, limited menu. At least they want to have cash flow. So again, we also should bring out our margin. If your profit margin on a case would have been maybe 30%, I don't know, you have to now bring it down to 20, 15, or whatever. It depends from practice to practice. There's something that you have to decide for your own. And then making the whole process of financing and payment for the treatment more easily adjustable to the patient's needs so that they can afford it. So the areas to be considered and take-home message would be treatment planning considerations. We have consultation and case presentations that had to be taken care of. We have financial considerations to talk about with our patients and take into account. We need to have a sound background in geriatric psychology, staff training. We have to look into that. We have to set up our office so that it is easy and it is kind of a homecoming for our elderly full arch candidates. And we have to think about the post-treatment consideration. So I would like to finish my presentation. I'll be more than happy to answer any questions down the line.
Thank you very much, Doctor, for the wonderful presentation. Yes. Yeah, good tips. Moody pastime, very great tips. Let's switch the gear, and I would like to bring in our sponsor, Darius Samarkian. He's a CEO for Synergy Specialist. Darius, All yours.
Thank you so much, Dr. Prasad. Thank you, Dr. Rana and the IDA. I've been really enjoying this presentation, Dr. Mostafavi. Thank you so much. For those of you in the IDA that don't know Synergy, we're the agency for specialists. We operate nationally. How our model works is practice owners contact us and they ask for guidance as to how to set up an in-house specialty program. Specifically, since we're on the topic of full arch and pros, in California, we have several prosthodontists that are available to come in part-time and help build that ecosystem that you need to develop a full arch program. Aside from getting you set up with not just the prosthodontist, we can also get you connected with a multitude of vendors that we've kind of gone and handpicked to come and help out with developing the system. Vendors such as front office coaches, billers, implant companies, so on and so forth. And we're looking forward to seeing if we can help team up with some practice owners out there that are motivated to help develop an in-house pros program. All of our pros, for the most part, are surgically trained, just like Dr. Mostafavi's vast experience. So they could also do not just the prosthetic component, as well as the implant and surgical component as well too. We've put together a full framework around this. I'm sure there's a lot of questions. Thank you for your time.
Justerius, thank you very much. And from RF America, I think they changed their name to Ray America. Mark Matamis. He is a national sales director. Mark, all yours.
Thank you, Dr. Prasad. Thank you, the IDA. And I do want to explain, RF America is one of our top dealers in the West Coast. I'm speaking from Ray America. Let me just share you my screen so I can show you some slides. Okay, great. Okay, so who is Ray America? Basically, Ray America is a company that CBCT company, and we originated in 2004 in Korea. We were part of a major group named Samsung for quite a number of years. As of 2015, we separated from Samsung, and we expanded now to about 70 countries around the world, worldwide. One of the interesting things about our products is we have about 4 different top models. They're all based on one chassis, one body type of a machine, kind of a different concept. And the reason for that is for scalability and upgradability in the future. One of the things that we did, because we have one body type for all our machines, we want to make sure that we incorporate that. We were able to accommodate every patient's body type. So if you have patients that are slightly larger, we made the machine slightly wider. We also incorporated a remote control feature that allows the assistant to walk around the patient very conveniently for easy positioning for the patient and the assistant as well. Each of our machines come with this separate 2D panoramic function and a CBCT function. So that way you don't have to over-radiate a patient if you just need a quick 2D Panorex. And one of the special features of our pano is that you can also collimate the field of view for the 2D pano. And here's an example of one of our pan images. This is taken about a 12-second scan. We have a special feature where you can superimpose a template system over your pan and be able to create a full mount series just from a Panorex. Okay, it improves the workflow for the office, saves time, and the key is it's not so much a software a feature. It's really more has to do with the way our machines rotate. And this feature is available because of the adaptive moving focus feature that we have, which means our machines can automatically adjust to the patient's anatomy during the scan. Then we can incorporate whatever size field of view CBCT that you prefer to use. So one of our entry-level machines is called the 3D Edge. Basically, it comes with 2 field of views, and it comes with an impression scanning capability. We're talking about full arch cases. you can now take your traditional impression, scan that to the CBCT like a desktop scanner, and be able to produce a DICOM, switch to STL, and be able to work with a full scan instead of an intraoral scanner. The Alpha Plus, one of the advantages we have here is we've changed the way we take positioning to another level by creating this blue light, this blue guided light. This allows you to see the actual field of view right on the patient's face. You don't have to guess where you are. You can actually see the height and the width. And we also extended that remote control so that you have full control of whatever height, whatever width you like, and you could see it immediately on the patient's face where the field of view is without having to guess. Okay, so one of the disadvantages of me being a bigger guy, I wanted to show pictures of basically certain machines in the market does not allocate enough space for a patient. They can have headroom issues, like the one on the left, the one in the center. You can see that there's limitation to the width of the shoulder. The ray scan machine on the right, you can see has enough room for somebody like me, and you can see the blue light on the patient's face for easy positioning. This allows you to be able to take a range of images ranging from airway down all the way down to endo. And the best part is you get to choose any which height you want. You want any height, any width, from a range of 16 by 10 to 4 by 3. It also is able to accomplish a 70 micron resolution voxel size. So it's one of the sharpest resolutions in the market currently. Um, Lastly, our model studio, Dr. Mostafavi was talking about the full arch cases and also being able to design a smile for a patient, dealing with their emotional response. It's hard to do that when you can't see the patient's face into the equation, right? So this machine basically allows you to take an extraoral imaging capture so you can get an OBJ file of the patient's face, superimpose that on the DICOM CBCT, and we can incorporate the STL taken from that scanner and combine them into one seamless volume for a virtual, like a virtual patient for full mouth rehabilitation. Anyway, for the sake of time, if anybody's interested in hearing more about our products, there's just a brief overview. One of the best features we have too, I wanted to explain is that we have a 24/7 support feature. It's called the IoT, which allows you to basically allows us to dial into the office. Something happens to your unit, it pops up in our database, and we're able to support you remotely. And this is available as part of our basic warranty. We had now extended our warranty up to 10 years with a 24/7 support. So feel free to reach out to me or to RF America, Jesse Polito, those guys are the ones who sponsored this event. I was asked to present so that we can go over the product. Feel free to reach out to me by email or cell if you want to do a demonstration. But thank you for having me.
Thank you very much, Ray. As I said, please stay back. We'll have some questions for you people. Doctor, yes, I do have some interesting questions. I'm going to go a little bit more technical in the sense, full arch, would you recommend all on 4 or would you say you would go 6?
That's a very interesting question. Well, as you mentioned, I studied engineering. I did not work as an engineer, but I studied engineering before I became a dentist. So much of my philosophies in biomechanics comes from engineering work too. So I'm not confident in restoring a full arch only on 4 implants for the simple reason that if any one of them fail, the whole case is gone. Whereas if I have 5 or 6 implants and 1 or even 2 of them fail, I still have another 4 or 5 to have the prosthesis serve the patient long term. So 5 is the minimum that I feel confident restoring an arch with, if not 6.
Thank you, doctor. The next question is, how do you set up in-home financial program?
I have heard on a couple of webinars that I have attended by ADA that there are some vendors who are now, probably Darius can give a hint on it. There are a couple of vendors, if you look at them in the internet, they come in and then they get in touch with you and they set it up with you. I'm not 100% sure how they do it, but it seems that in-house financing is becoming a trend in dental practices here in the US.
Thank you. The next question, kind of interesting question. It says, sorry, sounds like a dumb question. I don't know baby boomers.
Okay, so it was the second slide that I showed. Baby boomers are those who were born in early 60s, like me, till World War II, the life expectancy was 50, 55 years old maximum. But after World War II, there were major improvements in all areas of science, including healthcare. Industrialized countries had a major economic boom, and that led to an increase in the life expectancy of the people. So when the life expectancy was 50 to 55, now we are looking into life expectancy of in 80s for male and 90s for the females. So the concept is that now that you are living longer, when you reach the age of retirement, okay, and this is something that has not been thought of before, okay, now that you have reached the age of 60 or 65, you are retired, you don't have a job, but you do have a sustainable source of income. You now are engaged in a life wherein you travel, you enjoy your life, and there are multiple issues and things that you look into, whereas during the age where you were employed, you did not have an opportunity to look into.
Thank you, doctor.
Welcome.
I got one more question here. How about oral hygiene? How hard it is to maintain the oral hygiene? Do we have to remove the prosthesis to maintain the oral hygiene?
That's a very good question. Depending on which protocol, which type of protocol you follow, unfortunately, what I see in many of the pictures, you see that. Let me share the screen and bring that picture. Unfortunately, in many cases that I have seen, there isn't enough room for cleaning underneath the prosthesis. Okay. Now here, if you see, especially in the lower, you see this area, you see this area, and you see this area. So these are the areas wherein you can easily pass a thread, pass a floss underneath, and then clean underneath. An easy way of doing it would be to use a water pick, and then again, depending on case by case, depending on how clean the patient is able to keep the prosthesis, you may want to have a professional cleaning session wherein we unscrew the prosthesis, remove it, clean underneath, see how the tissues are, and then putting it back on. To answer your question in only 2 sentences, in the first year, I would remove the prosthesis every 3 months. Once I'm convinced that the patient does know how to clean the underneath of the prosthesis, then onwards I will do it every 6 months. But a lot of it depends on how you shape the underneath of the prosthesis. Okay, it has to be kind of not a ridge lap. It has to be kind of like an egg shape, so that there is no dead space underneath the prosthesis for the food to go and get impacted over there.
Thank you, Doc. Darius, are you still there? Would you please go through your surveys in the sense, how do we bring the doctor in, and what is our obligation, and what is our financial obligation? And we want to have some rough ideas to what would be our financial obligation towards the doctor. Since we have a little bit more time, he can kind of help us out at this time.
Sure, I'd be happy to answer that. The model that we have structured for surgical pros is broken down into 3 phases, right? Consult, surgical, and feeding the prosthetic. Specialists, obviously, they need some sort of per diem involved, right? But it's difficult to put a per diem type of situation together without looking at the full picture, right? Because you have technically, let's say, a calendar quarter's worth of treatment days to fill. So we structured a model where the pros gets introduced through synergy to your practice. They come in with their small equipment. Preference has been that a lab technician be on site and local for these types of setups. The cost of the lab fee, along with the cost of the titanium, which includes the prosthetic components, along with the surgical implants, and the patient finance fee would get split 50-50 from the top line production. So let's say, by simple numbers' sake, we have a $50,000 full arch case, right? The cost of materials and so on and so forth came out to $5,000. That leaves $45,000. The cost of the lab came out to, let's say, $5,000. That leaves us with $40,000. And miscellaneous with the patient financing fee were dropped down to $35,000, right? From that $35,000, we split it 50-50. The payment is finally rendered once the finance company pays in full. And we would introduce multiple finance companies to you guys. In fact, there's one company in specific that we are teaming up with that is essentially the kayak.com of patient finance companies, where you go online, you submit the patient's info, and based on their credit history, they'll fight for the best rate out there. And as far as liability and warranty, I think that's like kind of a question on many people's mind. The arrangement will be put in place where the liability of the prosthetic component, should something happen, would be up to an extended limited period of time to make sure that things are working properly. I will be emailing out something to everybody describing this after the webinar.
Okay, Darius, continuing with the same thing, who decides the fee structure? Is that we are going to decide, or the specialist has got to say anything? Because we had to, if you know the patient, we had to discount that fees and other things, and I hope it will be agreeable from the specialist. So, what's your take on it?
My take is that you have to go with what works for your demographic. At the same time, it's a fine balance that you have to keep because some specialists have a certain threshold to their flexibility of how much they're willing to drop their fee. And then there's another consideration to this, Dr. Prasad, which is what if the general dentist says to the pros, I'll take care of the restorative, help me treatment plan it, and you do the surgical part. That's okay too, right? In which case, we got to come to some sort of strategic consensus amongst each other as to what the fee would look like. How much of it would get a portion for prosthetic, how much would get a portion for the surgical portion, right? And that's in the case where you want to split it up, and you want, the GPs being the restorative doc in that setup. And by the way, I also wanted to mention Dr. Mostafavi is available. He resides in Dallas, Texas. His daughter recently graduated from Baylor Dental School, and so he wanted to be with family. So he's available remotely to help out treatment planning, full arch cases with you guys from start to finish. There is a fee for it. It's not much. We're talking like $200 a case, but we just want to be able to support you guys to make sure that things are very comfortable with taking on these cases should you need any clinical support. Not that the pros that we would match with you wouldn't be able to help you out, but at least we have like somebody dedicated available on a scheduled call if need be to help guide on the treatment planning.
Thank you, Darius. Mark, we have a couple questions for you.
Sure.
One is, if we buy the basic machine, could that be upgraded in the future to other things, other features?
We do have an upgrade or trade-in program that we implement. One of the advantages of our machine is they're all built on the same exact platform, so there will be zero changes to the footprint. The same exact machine with more features. We can't guarantee in the future any future models are going to be able to upgrade from your basic, but we'll make sure that we can do a swap or trade-in if necessary. But not a problem at all. Yeah.
Would you go through that software again? You mentioned right on the panel, we can section it, we can visualize everything on the panel.
Sure.
Would
Do
you
you want me to
please?
show the screen a little bit?
Please.
Okay. Yeah, so basically, if you guys can see my screen, so from our panel, we have a template system. It's a software that we provide you. It's free of charge. It's part of our system. It allows you to basically, you can manipulate each box and align it properly, and then you press of a button, it basically crops it to a full mount series template. Okay.
Wow.
But the trick is, if you look closely, I'm not recommending that you throw away your sensors. Obviously, this is just for to work in conjunction with your intraoral sensors. But it took me 12 seconds to do that whole thing, as opposed to if I was to individually take a PA or bite wing, have to angulate the cone at the right angle, it'll take me maybe 15, 20 minutes, right? And maybe do some retakes. But so the trick here is not so much the software, because if you look at each bite wing and PA, you don't see a lot of overlaps, very, very minimal. And the key is it's not the software that could do that, because the software has no clue about your angulation. It really has to do with the way the machine rotates. So the way our machine rotates, it's got an adjustable moving focus or adaptive moving focus. What it does is the machine will automatically adjust to the patient's anatomy. So it doesn't ask you those questions, unlike on the other simpler machines out there. Will ask you a question: is it a U shape, V shape, or square shaped jaw? And based on based on the instructions that it receives, it'll follow the path. Our machine does not ask that question. It auto detects, auto articulates. And because it does that, it's able to give you the right angulation for each bite wing and PA. So cropping the image with a template is not enough. It's just a software function. but to get the right angulation has to do with the rotation of the machine itself. And that's the basic unit. It's called the Edge. It comes with that. In fact, all of our models have that basic feature of the full mount series. Okay.
Does the software integrate with our practice management software?
Yes, sir. No, it absolutely does. We're an open source system, which means that we are able to integrate with any imaging software out there. We can even twain your Panorex into your existing imaging software, so we don't have to reinvent the wheel as far as the integration process. So we will keep your imaging software as is because historical data still exists in your imaging software. So all we're doing now is piggybacking off of your current environment. For the 3D, we'll provide you with an actual 3D rendering, 3D software to manipulate the images with.
How much it would be for a CBCT machine, and also, or I'm talking about ray scan.
Yes, sir.
Would you do any financing? Would you talk on that, please?
We work with the I mean, we're any financing company out there. We work with several of them. We definitely try to make it as easy as possible. As a manufacturer, all I could do is set up the actual MSRP or market price. We have dealers like RF America in your local region that basically has certain certain promotions during the season, especially post COVID. So our MSRP is almost not even relevant because the local dealer will have to provide what the market demands are. So I mean, the basic unit right now was market priced at around 65K with a 10 by 10 and 10 by 5. That's the Edge machine. The Alpha Plus with the flexible field of view was market priced at around 85K. We have the Studio, which gives you the face guide at around 145. Without the face guide, it was around 115. Post COVID, I guess I would recommend to contact RF America for pricing. They might give you some special promotions. But what we did do as a manufacturer for COVID was we doubled our warranty. Initially, it was a 5-year warranty, bumper to bumper. Now we've extended that to 10 years. So it's a 5 years full coverage. Year 6 to year 10 is parts and labor. I'm sorry, year 6 to 10 is the essential parts, which means the tube head and the sensors are covered. And then the 24/7 support, we extended that for 10 years. So I don't think there's any other company currently that gives you the 24-hour support, 24-hour online support.
Would that include hardware, software support, or how does it work?
That is correct. So what we're able to do is we're able to ping all of these units from anywhere around the world. So we have a way of detecting your network ID for the machine. So all the troubleshooting is done remotely by the manufacturer. So let's say it happens on a Friday afternoon, and you guys are left for the day. That machine is still live. We can still connect it through an IP address. So let's say at that time we have an office in Vancouver that might be monitoring the system. It could be Ray Korea, it could be Ray Japan, it could be Ray China, it could be any part of our Ray global network that could be monitoring that system. So basically, based on our global presence, we'll alert the local office and say Dr. Prasad's machine is having a problem. We will dispatch a technician from our dealer, RF America. The difference is when they show up, all the troubleshooting's been done. So they show up with the parts ready to install because the manufacturer had already been involved and we've already basically identified the issue. Does that make sense?
Yeah, absolutely. And I do have one more question while you're there. When you scan an impression, does the software create a model by means of inversion technique?
Good question. So basically, when we're scanning from a CBCT source, so basically the format of the file is a DICOM format. We would need to go through a conversion to STL, so before you can send that to your lab. So we do provide a conversion software, a third-party conversion software, but we do have partners that like labs or so forth that we work with, Blue Sky Bio, ExoCAD, and a few others to name. will actually provide the conversion for free as part of their services. So, but from a CBCT model scan, it's a DICOM, and then after it's converted to STL, then you can send it to your lab or print it or with an output device. But thank you, good question, sir.
And I'm just getting confused with this question. Talk about the upgrade. Okay, regarding the upgrade, and I got a panel, and if I need to buy software, which convert panel to FMX, how much would it cost? I hope my question is clear to you.
Yep. Well, like I said, the feature that we give you, the FMX conversion feature, is available in our model. This is not something that we sell separately per se, but when you go for an upgraded machine, that's part of our basic feature, because the software is not what converts the image; it's the rotation of the machine. So if your machine doesn't rotate at the right angle, then the software doesn't really do you any justice, because if you're not getting the right angulation, then you're not going to get a successful bite ring or PA. So it actually comes in conjunction with the machine. But just to clarify, we don't sell our software. We don't charge for our software. When you purchase a package from Ray America, we give you the software as part of the investment. So the license file and the software is included with your purchase. We don't sell those separately.
Okay, just for the information, doctors, Jesse Pulido. He's the local manager right here.
Correct.
He could be reached at 818-981-7573. Please reach him out. Jesse Pulido, 818-981-7573. And I do have one more question for you while you're there. One second. I think stay back, and I might have a few more questions for you.
No problem, Dr. Prasad.
Okay.
Thank you so much for questions. Feel
All
free.
right. Doctor, are you there, doctor? Since we have a little bit of time, you think you could talk a little bit more on all on 4 or on all on 6, if you are ready with that? Are you there, doctor?
Yeah, if you give me a couple of minutes, I can look into my computer and bring up a case and we can discuss it.
That would be
Sounds good?
nice. And
Okay.
especially if you could talk on the prosthetics, we have some time. We
Yeah.
can go. We can take good 20, 25 minutes, and
Okay, give me one
that's
second.
going to help us a lot. So while he's working on that, again the question for Darius. Are you there, Darius?
Yes, sir.
Please run the whole process as to what we need to do in terms of getting the specialist, like a brief up for the doctors.
Sure.
The entire process, please.
Process is getting started. Visit our website, synergyspecialist.com. Click on the Practice Owner tab. It's right on the top of the home page. It's a elongated oval orange button. Fill out the application. It's a registration form. There's no obligation for filling that out. We just want to get to know the practice. For example, if you have left or right-handed type of delivery units on the chair, for example. In this way, we're able to find you the best match possible. Like I mentioned, in California, we have several surgical pros available. For the most part, they're located in Southern California, but they have no problem traveling to Central Cal or even Northern Cal. We have logistic coordinators to help and concierge the travel through. And as far as marketing, it's something that you have to start discussing and analyzing with your existing marketing company, or possibly you might want to think about looking into a marketing company that focuses on full arch. There's a handful of them out there. I noticed that they're all good at like a specific element within the full arch marketing realm. I can also share with everybody that this may be news or not, but the group that in the U.S. that just completely owns this space is called ClearChoice. I'm sure the name has been very familiar. Their model is such where they market directly, only full arch to patients directly. They're not referral based. Patient comes in, their TC treatment coordinates these cases and to perfection with case presentation, and the case gets paid up in advance. From what I understand from a lot of the former ClearChoice management members that I've had discussions with, they said that usually these cases are paid in advance before they even see the surgeon. They built the whole science around from the patient coming through and leaving. I think Dr. Mostafavi would be able to put a lot of education and emphasis for anybody that's looking for it, as far as like developing that ecosystem to make sure that psychologically the patient, like Dr. Mostafavi was saying, is very understood and comfortable moving forward with these cases.
Thank you. Are you ready, doctor?
No, I'm looking for presentation that minute. Give me 1 minute.
Okay, and there is one more question for you. Do you use any specific laboratory for the prosthetic work? Any
So,
lab you would recommend?
mm, so as far as the lab is concerned, can you hear me?
Yes, go ahead.
Okay. DDS lab in Florida is a good one. And then, of course, Glidewell, which is based in California too, is a good one. But what I want to bring out is that there should be a mutual understanding between you and the lab technician who is dealing with the case, so that you are both on the same page. One of the most complicated issues technically during the process is that, so here comes a case, you extract the teeth, you give the denture a set of upper and lower, we call it interim denture or temporary denture during the healing time, okay? And then you place the implants, and what typically happens, you have to start the case from scratch. Set the teeth and trying, framework, trying, and then wax trying on framework, and then go to the final, which takes at least 5 visits. Going back to the lab and coming, you are talking about at least a month between each of these procedures. So that makes the whole process a very, very time-consuming process. That's where the patients are fed up with so many visits, and then they try to push you to get the case done, and now here you are without having enough information as to where you want to go. We can have a different presentation on how best you could utilize to minimize the number of visits, so that once the implants are osseointegrated, you can get the case done in as few as probably 3 visits. Did I answer your question?
Yes, doctor. Yeah.
Okay. I'm looking into...
If you want to take a couple more minutes, that's fine. We do have some questions for Mark.
Oh yeah, that would be perfect. I have a
Mark, are you
presentation, but
there?
I'm looking.
I'm here.
Okay. Does the warranty cover the labor?
Yes, the labor is covered in the first. Actually, the manufacturer covers the 2 years of labor in the beginning, and then the RF America folks will be covering the difference in the labor. But we've extended that to 10 years, so the first 5 years is covered. Years 6 to 10, it's prorated, depending on the year.
Okay.
But again, a lot of the question of the labors is definitely a fair question. Like I was saying earlier, because we have the 24/7 support with the Ray IoT, a lot of that labor is cut in dramatically because we don't really necessarily have to send a technician to troubleshoot. Unlike the other more simpler models, they would basically send a technician, troubleshoot. They come to the office, they take a look, and then they say, Dr. Prasad, we'll come back next week when the part arrives, and then we'll install it, right? That doesn't happen anymore because we have a proactive approach where the manufacturer can dial in, troubleshoot the unit. And if we find out there's a part that needs to be replaced, the technician shows up with the part ready to install the machines back to normal a lot quicker than the traditional method. So labor has not been really a factor with some of these warranties, but the support and the response has been cut dramatically because we actually find out there's issues with the machine before the office does with this IoT support. So there's always someone monitoring the machine. So that's one of the advantages of the 24/7 support.
Mark, the next question would be data backup. Is it our responsibility or do they have a problem for backups?
Data backup, I would urge the office to. I mean, that's really the responsibility of the office, right? You're responsible for your data. As far as our images, they're normally backed up on the acquisition computer, which we provide you. You're definitely welcome to replicate or duplicate some of these files and put it in a backup storage system. RF America team has a service. I think they use First Choice IT is one of their companies that they use in the local area there. They can definitely consult with you as far as creating a backup structure for the office, but that's normally the office's responsibility. The good news is when you take an image, the raw image gets saved on the acquisition computer we provide you. And if you decide you want to get a copy of that over to your network, you're welcome to make duplicates of that, but you never lose the original image. So there are times when the image can get lost during the transfer. Let's say the practice management wasn't responding during the time of the scan, then our system will automatically house a copy of it in the acquisition computer. When the practice management comes back up, we can transfer the files over manually. So there's always a redundancy as far as what we provide on a regular basis. But I would definitely consult with your IT company that you support that supports your practice. If not, call RF America. They do have an IT service provider that they can recommend to you, which is First Choice IT. I believe, in your area. And we're not opposed to you calling Ray America for support if you're having some hardware issues. We'll definitely advise you on that as part of our support.
Thank you.
Okay.
Doctors again, Jesse Pulido, she said he can have one-on-one if you need to have, I mean, if you want to have a demonstration. And I just passed on the number. Jesse, would you post your number once again, please? Synergy Specialist, their telephone number is 213-805-6282 or 1-800-684-5479. Darius at synergyspecialist.com. That's the email. And Jesse's number is 818-981-7573 for pricing questions and schedule one-on-one demo. Again, I repeat, 818-981-7573. Yes, there is one more thing Jesse mentioned. He said they will provide data and backup support. They had a question about the backup. They will support that. Thanks, Jesse. Doctor, are you ready, doctor?
Yes, yes, I'm ready.
Please go ahead. Go ahead. Now the time
Okay.
is 11:20. You can take your time.
Yeah, okay. So I'll go quickly through this case and then you let me know whatever question at whatever point you have. I try to go as fast as I could so that we can see the case from start to finish. So here is one of the cases, medical condition, dental history. So this is a case that I showed you. So multiple decays. I just want to go through how the thought process was that we ended up doing this case the way we did. Okay, so let's have a look at different angles, and then this is the panel of the patient. You see multiple areas that are needed to be treated. A major criteria for deciding what we did for this patient were these two canine teeth, okay, that were impacted, and patient did not want to extract those impacted teeth. So we did a CBCT. So as a part of pre-operative diagnostic, before you want to present the case presentation and your treatment options to the patient, what you want to do, you want to gather as much information as you could, an upper alginate, lower alginate, and a bite registration mounted on the articulator, a good panel, FMX, and a CBCT to evaluate the bone condition, any impactions or whatever. So in this case, we analyzed here, we saw the impacted teeth, okay, and then we went on virtually placing implants. As you can see, our implant is impinging on these teeth. So we thought of other treatment options, what else we could do in order to reach our goal. The patient obviously decided on having something fixed, and our treatment plan consideration were considering the patient desire, what he wanted. He wanted to have something fixed, number one. Number two, he did not want to touch those canine impacted teeth. And then, so that was our limitation. And then we have to sequence the treatment from start to finish. So let's go consideration. Okay, treatment. Our treatment plan was in maxillary arch, retaining the molar teeth, and then a screw retained from premolar to premolar. Now, based on our prosthesis design, now we come and select in what areas do we want to place our implants in the upper arch. In the lower arch, it is much more easier, total extraction, and implant supported fixed detachable complete denture. That's the scientific term for a typical hybrid denture. Okay, so treatment sequence, one of the most important things that you want to consider when treatment planning full arch cases. So your treatment is into these phases: extraction, healing time, temporization. You cannot have the patient go around without having any temporary denture. One of the first things that I, as a restorative dentist, consider is that I do not want to have my patients being without teeth even for a single day. He may not be very functional especially immediately after extraction date, that's a different issue. But I do not want my patient to be without teeth even for a single day. So extraction, temporization during the healing phase, after 2 months or 3 months, depending whether you have grafted the area or not. You do a CBCT, you analyze the condition of the bone height and volume, and then you plan on placing the implants virtually, depending on which software you are using, and depending on which type of prosthesis you are planning for the case. Now, what type of prosthesis to be selected for which case, that's an entire different scenario. You have to look into the transition line, the smile line, the patient desire, whether fixed or, and the patient finances, how much the patient can afford, and so on and so forth. So those are the considerations that you take in while treatment planning a case and while sequencing a case. So extraction, temporization, implant placement, and then starting work on getting the case to finish. So these are the phases of the thing. So we analyze each and every of our prospectus implant positions. We measure the height, we measure the width, and that's where a good quality CBCT comes into the picture. So these are different areas. You see the teeth number over there where we planned for placing our implants. Now, this is the prosthetic workflow, we call it. So interim dentures to provisionals after extraction. And we want to have these interim dentures as close to the final prosthesis as could be, in order to minimize the number of visits later on during the final prosthesis fabrication. So extraction. So what you do, you don't want to extract both the upper jaw and lower jaw and then at the same time, and then go ahead and give reline your temporary dentures. Instead, what you do, you want to extract one jaw, usually the upper jaw, because I have all this palate that has not changed at all, that I can index or I can have a reference to when I'm relining and placing my temporary denture. Very, very important. So what I do not touch the lower teeth. I extract the upper teeth. I reline my upper denture with any kind of reline material. My material of choice is GC Cosoft. I like it. So I reline the upper, utilizing not only the upper, the roof of the palate to index to my upper denture, but also I'm utilizing the lower dentition to make sure that I'm having the upper denture in place for a good occlusion, as you can see here, right? Then, after I have relined the upper denture and I'm convinced with the position of the upper denture, now I come and extract the lower teeth, and then now I index or reference to my lower denture against the upper denture. Okay, and I reline it in that position. It is very, very important. So this is the upper and lower arch after the healing time. This is the process that we did in the lab in deciding where the teeth should go. So this line indicates where I want to have my lower occlusal plane. This is where I did osteotomy, mock osteotomy on the cast, on the working cast, on making the upper denture, upper temporary denture. What you want to do, you want to have half the dentition untouched. You place the teeth. These are the technical issues, but it is very good for the restorative dentist to be on terms with the technician, or rather guide the technician as to what we want. So what I did, half the jaw untouched, half the jaw I set the teeth to my idealized occlusion and position. And now it's just a piece of cake to mimic this half to resemble this half of the dentition. So this is my upper temporary wax up. This is my lower temporary wax up. What I want to do, I want to try in this wax up before I fabricate my my CBCT guide. Look at the occlusion here, the overjet and overbite. Here I'm looking into the size of my dentition, the margins. This is the smile line, and this is my wax up brought into the mouth. As you can see, I don't have a flange here. I don't want the flange to give me a fake sense of bulking up of the lip. I want to see how the lip support is with the teeth, because the upper lip, as you know, is supported by the upper dentition. So if you have a flange here, you get a fake sense that your upper lip is protruding too much outside. So you scan your wax up, you scan the dentition, the arch. Then in this case, we send all these informations to the anatomage, and we decided to do a restricted guide surgery. Again, I mentioned a restricted guided surgery for the upper arch. Why? Because in upper arch, remember, the canine impacted teeth were very, very critical, and we had to be as precise as one could be in placing our implants. So a restricted surgical guide, as you can see here. All right, and this is our model. Okay, so this is for the upper arch, and here you can see implants in the upper arch placed. Contrary to the upper arch, where I had a restricted surgical guide to guide me as to where exactly my implants have to go, in the lower arch, because the final treatment plan was a hybrid denture, all I was concerned, or rather all was needed from a surgical guide, was to make sure that my implants are not protruding through the labial, but they are rather towards the lingual or upright. So just a simple surgical guide, which was a duplicate of the temporary denture with let me see if I have a picture of it. No, I don't have a picture of it. Okay. With a slot from the molar of one side to the molar of the other side, and then I place the implants in molar, canine, and molar. Okay, so, and here you see the impression. Another hint is that in these cases, you definitely want to have a open tray final impression. Oh, sorry. Yeah. So that was, I have another presentation that I could not find it that goes through all the steps of fabricating and then trying the framework. Unfortunately, I could not find that, but I'm here to answer any question that you might have.
Yes, doctor, I do have a question. In terms of interim denture, I'm talking over denture, do we have to cover the palate, or can I cut short, make it like a horseshoe-shaped denture?
It depends what type of arch you are dealing with and how many implants you have. If you have a square arch or round arch, not a V-shaped arch, you can get rid of the palate provided you have at least 4 implants in the upper jaw. Ideally, molar, molar, canine, canine. And then make sure that the thickness of your acrylic is sufficient enough to give some rigidity to your overdenture. If not, what the lab can do is integrate what they call a mesh, a wire mesh, into the flange area to make it sturdy and strong.
Okay, what if it is 3 implants? How do you design it?
I would try to convince the patient to have the palate. And in the meantime, I would place my 4th implant and bury it underneath, giving the patient an overdenture on the other 3 implants with the palate, promising to the patient that as soon as osseointegration of my 4th implant is done, at that time, I will cut away the palate and then restore the case on 4 implants. In many cases, I have realized so let me say this. I have been a private practitioner for about 20 years or so before I entered the PROS residency program. Okay? And I learned a lot from the mistakes that I did. Many a times, we prejudge our patients. Okay? If we make our patients understand the difficulties that we have in pleasing what they want, then they will come in our side rather than sitting on the opposite side. So let's say in this case, if we convince the patient that, hey, I can cut away the palate, but I cannot guarantee that the denture will last you long. It is going to break because it doesn't have enough support 1, 2, 3, 4. Once they understand the problems, then they will listen to us and they will cooperate with us.
Thank you, Doc. And again, this will be a different, my own question. Why do the screws become loose and how do you prevent it?
Very, very good question. Very, very good question. Again, very, very good question. Number one, so we are talking about all possible scenarios, okay? Scenario one, I will look into whether, to begin with, I have torqued the screw to the recommended value or not. That's number one. Number two, I will look into whether I have checked the occlusion in centric and eccentric movements. I guarantee you 90% of the time, we only check the occlusion in centric. We do not check it in eccentric. So I will first check the occlusion in centric, tap, 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 and then I will tell the patient to bite and then move the jaw to right and left. And I see whether there is any excursive point on my restoration. Usually that's the case. That's the second thing. Third thing, invariably, after about 2 weeks or so, I will have my patients to come in and I recheck the occlusion. And we have to keep doing that, rechecking the occlusion every 6 months. Why? Because, as you know, the rest of the teeth are all in PDL and everything keeps changing. Whereas my single implant, which is here, it stays the same. So what happens over the time, while other teeth are adjusting to the physiological occlusion, the occlusion on the single implant will be much more than what it was when I checked it. So it is a very good habit that when you see the patient that you have placed an implant, whenever they come for any kind of recall, whenever you get a chance, you just check the occlusion. So that's number three. I think these are the possible things that I could think of: occlusion, and forces.
My next question would be, how often do you change the screw? That's number one. Do you have any preference for the articulating paper? What kind of paper would you recommend?
Okay. I do not change the screw unless and until it is worn out. There was a time, and it started from Nobel, that said every time you open, you take out the prosthesis, you have to change the screws, but that applies to the small prosthetic screws that Nobel uses. Okay, so we have two types of screws. We have a small screw, which we call it a prosthetic screw, and it is used in hybrid kind of prosthesis. You have it in Nobel and you have it in Straumann. You have another screw, which is a long screw. So those long screws you do not need to change unless they are stripped or you see any visible damage on it. Whereas the tiny screws that is used in Nobel or Straumann in case of Synocta multi-unit abutments, those I would recommend to change as often as you could. Yes. Regarding the articulating paper, the one I recommend is by Bosch, B-O-S-C-H, Bosch articulating paper. And on top of articulating paper, I use shim stock. Shim stock is a 6-micron thickness of aluminum sheet, which you place in between the teeth. And in case of implant crown, what I want to achieve is I first want to get rid of any occlusal interference using my marker, my articulating paper. Then, as a final check, I place the shim stock in between the upper and lower teeth and have the patient bite on it, and I kind of gently pull the shim stock. If it tears, that means my occlusion is tight. I again will trim it. Okay? I want my implant occlusion on centric. When the patient bites, I want to be able to gently be able to pull away the shim stock from in between the teeth.
Okay. Thank you, Doctor. That was really an excellent presentation.
You're welcome, sir.
Doctors, if you don't have any question, I will wrap it up, and you will get 2 units for today's meeting. As said, if you have questions, post it right away. Thank you, Dr. Mostafavi, and I would like to thank Mark and as well as Darius for your sponsorship. And we will see you folks in about a couple weeks.
Thank you.
Doctors, thank you very much. We'll
You're
catch
most
you up
welcome,
in
sir.
2 weeks.
Thank you.
Bye-bye.
Have a good day. Bye-bye.
Have a good evening.